Good afternoon. We don't get to have referrals of toxic patients every day, but when we do, what type of anesthetic technique do we usually utilize for our patients? Okay, so this session would want to discuss with you regional anesthesia and its benefits on the high-risk patient for surgery. So these are the following objectives for our session. We would want to identify the high-risk patient for surgery, present evidence on the outcomes of regional anesthesia for the high-risk population, and then we would want also to discuss and review the techniques that we can utilize for our high-risk patients for surgery, right? Okay, so who is the high-risk patient for surgery? They say that the high-risk surgical population accounts for 12.5% of surgical procedures, and mortality rates of this population would range from 5.8% to 25%. However, when you look at literature, you cannot find one paper that will really identify and define who the high-risk population is. So in 2006, Pierce and his colleagues tried to identify the high-risk patient in the UK. No? So what they did was to search the database available in the UK, included patients who underwent general surgery, and those surgeries that were that carried a 5% mortality rate was tagged as high risk. Okay, so the results of the study were as follows. They identified patients who were 75 years and older who underwent emergency surgery and with a long duration of hospital stay as high risk, right? Deaths are most common in this population. Okay, so older patients, those with coexisting medical conditions, and those undergoing these types of surgeries. That's why these comprise the high-risk population. Okay, so why is it important to identify these patients? For us to be able to prepare for our anesthetic plan, for us to decrease the chances of morbidity during the perioperative period. So we will be able to inform our patients well, inform their families as well, regarding the risks of the risks that the surgery would have. Okay, so also knowing that the patient is high risk, will be able to request for the right ancillary procedures, optimize the patients prior to surgery, make proper referrals to our colleagues to help us optimize them prior to surgery. Okay, so if ever ICU admission will be required and ventilator support as well, we can inform the family and the patient and make them prepared for what, or make them prepared on what to expect after the surgery. Okay, so again, the appropriate perioperative management, knowing that we're dealing with the high-risk population, will make us plan well for the chances of morbidity and mortality to be decreased. Okay, what about the type of surgery? Will it affect our management? So this paper tried to come up with a list of surgical procedures that would be high risk. All right, so according to the authors, patient-specific factors as well as operation-specific factors contributes to the operation being a high-risk one. Okay, so these are the factors that, according to the study, these are the factors that would contribute to the surgery being high risk. So when a surgery is an emergency procedure, if it had an increased OR time with significant blood loss, if the patient had hypotension or bradycardia intraoperatively, if the patient required ICU admission or a long hospital stay, these all contributed to the operation being high risk. Okay, and these are the list. This is the list of procedures that the authors came up with that they tagged as high risk. All right. So knowing that we are dealing with a high risk patient or a high risk surgery, what anesthetic technique would be optimum or would be appropriate for these patients. So I will be presenting the evidence on the benefits of regional anesthesia for the high risk population. All right. So the surgical stress response, okay, is known to be the reason why there is a lot of morbidity and mortality in surgical patients. So the surgical stress response would activate a lot of the release of a lot of mediators causing pain, would also activate the neuroendocrine metabolic system that would increase the release of catecholamines. Also, the immune system and the hemodynamic systems are affected. Okay, so what does regional anesthesia do? Regional anesthesia, through its superior analgesia, attenuates the surgical stress response. All right, and they say that local anesthetics themselves have an innate property to attenuate this surgical stress response. So hopefully, if this response is attenuated at the beginning, even prior to surgery, then morbidity and mortality may be decreased. All right. Okay, so here's what we know about regional anesthesia. These are all well-established short-term benefits from this technique. There is a growing evidence that acute post-operative events may have long-term consequences. So the goal right now is to prove that regional anesthesia has a benefit on long-term outcomes. Okay? So according to Fisher, in this article, regional anesthesia offers more than just pain relief. So he mentioned articles there suggesting that indeed there's a reduction in surgical morbidity and mortality, and there's better functional outcome when patients receive regional anesthesia. But he also stressed that we need a large study population to be able to demonstrate the clear difference in morbidity and mortality. Because right now, what we see are positive data when we look at trials or literature, no? Because all these are single institution trials with a small population. So I think the challenge right now is to come up with large trials with a big study population to be able to demonstrate really the effect of regional anesthesia on morbidity and mortality. Okay, one such trial was done in 2000. So this is a landmark study in regional anesthesia. It's called the Quartra study by Rogers and Associates, wherein they included 107 trials with 8,000 plus patients. So these patients received neuraxial blockade. They underwent major abdominal surgery. Okay. So as you see in the forest plot, the patients had a reduction in morbidity such as bleeding, vascular events, infection, and respiratory depression. So you see that the forest plot favors regional anesthesia, no? When you compare it with the other group that received general anesthesia. So they concluded, the authors concluded in this study that there was indeed a 30% reduction in mortality when patients received regional anesthesia. Okay? In 2002, another group in New Zealand tried to investigate further if regional anesthesia really had an effect on morbidity and mortality. So this was another multi-center study with 6 countries involved and a large population of patients, 915 patients. The trials included in this review were divided into 2 groups. Okay, so they had the population that received only general anesthesia, and the other group was general anesthesia combined with epidural anesthesia. Okay, and this was the study population. The patients included had the following comorbidities. Okay, so what did they find out? That there was no overall difference in the 2 groups, whether the group received general anesthesia alone or general anesthesia combined with epidural anesthesia. Okay? Okay. So this is another trial, another big review, no? Including trials that tried to answer the hypothesis that if you control post-operative pain, then cardiac morbidity in the post-operative period would be decreased. So among all neuraxial techniques, again, included in this study, it was only thoracic epidural anesthesia that had an effect on major outcomes. The rest, like lumbar epidural and spinal anesthesia, when given to the patients, they found out that there was insufficient evidence to conclude that it decreased morbidity and mortality. Okay? What about peripheral nerve blockade? So this paper reviewed trials on peripheral nerve blockade. And they say that, of course, there's a direct cardiac and the direct cardiac and pulmonary effects of peripheral nerve blockade is negligible, all right? And they only proved that the short-term benefits of peripheral nerve blockade in this review, no? They said that long-term benefits of PNB is still lacking due to inadequate data. However, they wanted to stress that the early post-surgical mobilization that you get from peripheral nerve blockade may have a long-term benefit. So we are looking out for papers having this goal to prove that PNB indeed has an effect on long-term outcomes. Okay. So what about the risks that our patients may get from a neuraxial technique? Okay, so this paper tried to find out if neuraxial blockade would increase the risk of clinically significant hypotension that would lead to myocardial infarction and or cardiac arrest. Okay, so they included patients that were enrolled in the POISE trial. So the POISE trial is a large study that tried to see the effect of giving a beta blocker preoperatively to patients undergoing surgery, and if giving a beta blocker would decrease morbidity and mortality. No, so some of the patients included in the POISE trial had a neuraxial blockade for the surgery. Okay, so what did the authors in this review find out? So they found out that when patients were given a neuraxial block, like spinal and epidural, there was non-fatal cardiac arrest or cardiovascular or non-fatal myocardial infarction after the procedure. So there was, they found out that there was morbidity, no, when the patients received a neuraxial blockade on top of when they received a beta blocker. Okay, so what is the take-home message of these trials? So I think it is a case-to-case basis. So I think you being the anesthesiologist should have a better judgment of what anesthetic technique to give your patients. Either general anesthesia or regional anesthesia, both have benefits and risks. Based on the studies presented, there's still a lack of evidence that regional anesthesia indeed has an effect on long-term outcome. Okay, so let us now review what type of regional anesthetic technique you can give your patient, especially the high-risk population. Of course, I will always start with my first love, which is peripheral nerve blockade, because among all regional techniques, especially if I'm dealing with a high-risk patient, peripheral nerve blockade is the safest because, like I mentioned earlier, the cardiovascular and pulmonary effects of PNB is negligible. Okay, so we would commonly get referrals of amputations or hip surgery, and the population that undergoes this type of surgeries is the elderly population, which makes the surgery high risk already. Okay, so what if our patients would have anticoagulation on board? Or, of course, knowing that they're elderly, it would be difficult to perform a neuraxial blockade on them. I would suggest that you do a peripheral nerve block on these patients. Okay, so these papers utilized the following: femoral nerve block, sciatic nerve block, lumbar plexus block on high-risk patients undergoing major lower extremity surgery. Okay, again, the benefit of giving a peripheral nerve block for high-risk patients for lower extremity surgery would be superior analgesia, early mobilization. All right. What about major abdominal surgery? Usually, we would just perform a general anesthetic technique on these patients. Okay. However, if you supplement your general anesthetic technique with a nerve block, like a fascial plane block, I believe that you will be able to decrease the requirement for patients for your inhalational and your opioids, which would lead to more hemodynamic stability during the operation. So what fascial plane blocks can be performed. Right now, what is gaining popularity is the erector spinae plane block, wherein local anesthetic is deposited in the plane below the erector spinae muscle, just above the transverse process. Okay, so we are able to block your visceral and somatic afferents due to the paravertebral spread of the local anesthetic. Okay, another block that you can utilize is your quadratus lumborum block. I think it's quite more difficult than the erector spinae block, but some regionalists would perform this. It's depositing your local anesthetic anteriorly, lateral, or posterior to the quadratus lumborum muscle, again targeting the somatic and visceral afferents, the abdomen. Okay, so according to these papers, either block would be successful in managing patients who are high risk for major abdominal surgery, because like I said earlier, when you supplement your inhalational or with your inhalation anesthetic with a block, then you need a lesser volume of your inhalational, or your the dose of your opioid is also decreased, leading to more hemodynamic stability during the surgery. Okay, what about vascular surgery? Vascular surgery in itself is a high-risk procedure. Okay, so patients given a block for vascular surgery, this paper explains, would benefit a lot. No? So for example, AVF creation. So before, AVF creation was just done locally, no? So either you just give an IV sedative, or surgeons would just give lidocaine, local infiltration of lidocaine. But there are studies saying that many times the AVF would be unsuccessful. No, the fistula, it would be difficult sometimes looking for vessels that would be patent for fistula creation. But right now, a brachial plexus block, if utilized for AVF creation, leads to more successful fistula creations because of the sympathectomy, the venodilation that results from the sympathectomy. Okay, so they say that there's more successful AVF creation if the patient is given a brachial plexus block. What about carotid end arterectomy? Before, this procedure was done under general anesthesia. But right now, doing a cervical plexus block on patients undergoing carotid end arterectomy, they say lessens or decreases the chances of stroke after the procedure. Okay, so again, these blocks, when utilized for these types of surgeries, would benefit patients who are high risk, most especially. All right. Okay. Hold on. Okay. So in summary, before we summarize everything, what about patients for airway management? So sometimes you get referrals for patients who have a difficult airway, and we would plan an awake intubation for our patients. Okay, so for this situation, usually we would just give a sedative and then just talk to the patient, no, while doing our fiber optic intubation. But they found out that when we do a nerve block, more specifically cervical plexus nerve block or a superior laryngeal nerve block on patients for awake intubation, then you would have an easier and faster intubation, and the patient would feel more comfortable, and also his hemodynamics would be more stable if he's given a block. Okay, so in summary, for the procedures discussed, PNB is safe, no? Especially if your patient is hemodynamically unstable. For patients who have anticoagulants on board, it would be safer to do a block. And also, if a neuraxial block would be difficult to perform, I would suggest that you perform a peripheral nerve block on patients. Okay. However, I would want to stress that we are now trying to shy away from doing blind techniques, no? or landmark-based techniques, you should have an ultrasound or nerve stimulator when performing your blocks for the patient to be more safe. Also, a lesser amount of or a lesser volume of local anesthetic is required if you are ultrasound or nerve stimulator guided, which decreases the chances of complications such as local anesthetic systemic toxicity. All right? Okay, now let's move on to neuraxial blockade. Out of all the neuraxial techniques that we know or that we utilize, I think that the spinal is or would make the patient more prone to significant hypotension because of the sympathectomy that it causes. Okay, so this paper tried to combine a spinal and epidural technique. So what they did was a needle through needle technique, and they injected just 5 milligrams of hyperbaric bupivacaine intrathecally and supplemented it with an epidural of 1 to 1.5 ml of bupivacaine until they were able to reach a T10 block height. And with this technique, they found out that there was more hemodynamic stability in terms of heart rate and blood pressure. Okay? What about continuous spinal anesthesia? I'm not sure if some of our colleagues are able to do this, no? Because as far as I know, we lack the equipment here in our country. Okay, the first time I heard this technique was back in 2013 when we presented a paper in Singapore during the ACA convention, wherein we presented an Eisenmenger case for cesarean section, and we utilized a graded epidural anesthetic technique. Okay, and the guys in Singapore suggested that we try doing a continuous spinal anesthesia the next time we encounter high-risk patients. No, so what is this technique? It is using a spinal needle with a gauge 26 or 27. And then threading in a catheter through the spinal needle. So I think B. Brown has this set. It's called SpinoCath. Okay. So, and then we inject local anesthetic through the epidural in a graded fashion. So if we give our local anesthetic like a hyperbaric solution in increments, then the slow onset of the block will let the cardiovascular system adapt more easily. So there will be no drastic drops in blood pressure or heart rate with this technique. So these papers utilized the continuous spinal anesthetic technique for the high-risk patient for these procedures, and found that indeed there was hemodynamic stability throughout the surgeries. Okay? What about segmental spinal anesthesia? We all know that when we insert our spinal needle above L1 or L2, then there is a chance that we may hit the cord. Okay? So this technique is injecting or inserting our spinal needle at the thoracic area, paramedially, okay? So is it safe? Authors who have made studies on this technique say that it is, because the thoracic segment of the cord lies anteriorly. And also a small amount of anesthetic is needed to be given to be able to get a segmental blockade. Okay, so some papers used 5 milligrams to 7.5 milligrams of isobaric local anesthetic for the anesthetic to just settle in the thoracic area. So what procedures benefited from this technique? Okay, so laparoscopic cholecystectomy, open cholecystectomy, breast surgery, especially if the patient is high risk, benefited from segmental thoracic spinal anesthesia. Okay, because like I mentioned earlier, the block is just within the area to be operated upon, right? And of course, let us not forget the good old epidural technique, wherein if we give our local anesthetic in increments, then there will be a slower onset of the block, affording hemodynamic stability. Okay, I think the only what would hinder us from performing an epidural is if patients are on anticoagulation. Okay, so because of the occurrence or the risk of vertebral canal hematoma, because out of all the regional anesthetic techniques, if our patients are on anticoagulation, it is the epidural technique that carries the highest risk of developing a hematoma, especially if the anticoagulation or anticoagulant is not stopped, no, before the procedure. So the lowest risk would be for superficial nerve blocks. Okay, so in 2010, the ASA released the third installment of the guidelines on regional anesthesia and the patient receiving antithrombotic and thrombolytic therapy. So in this guideline, in the update, we just included interventional pain procedures as well as neurorectal anesthesia for the parturient, especially on anticoagulation. Okay, and they just wanted to again stress that we have to balance the risk of surgical bleeding and thromboembolism. With this, bridging therapy is highly recommended. We cannot just stop anticoagulation, especially for moderate to high risk patients. Okay, so this is just one of the tables included in the guidelines. So as you see, for example, if the patient is on warfarin, it's recommended that we stop warfarin 4 to 5 days prior to the procedure and request for an INR. The magic number is 1.5, no? So if you have an INR of 1.5 or less, then it is safe to perform a regional anesthetic technique like a neurorectal blockade, okay, on our patients. So I suggest that you download this app. It's the Astra Coags app by ASA. Especially right now, there are a lot of anticoagulants being utilized that are new, no? So if you're not familiar with the name of the anticoagulant being given to the patient, then you just type in the name of the anticoagulant in this app, and the app will tell you when to stop the anticoagulant, when to perform the neurorectal technique or the nerve block technique that you plan for the patient, and then when to resume the anticoagulant again after you remove the catheter or the epidural catheter or after the surgery. All right? So I believe that after all the discussion we had, we were able to identify the high-risk patient for surgery. Also, we were able to review the evidence on outcomes of RA, especially the high-risk population. And again, we were able to review what techniques we can utilize for our patients, especially if they are high risk. Okay, so like I said earlier, again, it is a case-to-case basis. You are the best operator, the best judge to see what type of technique would best suit your high-risk patients. At the end of the day, it is more important whatever technique you use or you choose to use. Important is the patient is safe so that you will have peace of mind, and then you will be more confident, no? That the patient the patient you left after surgery is safe, no? So that at the end of the day you will be able to go home, stop being anesthesiologists, go home, be a mom and dad to the people waiting for us at home. All right, so with that, thank you very much for listening and have a good day, everyone.